Today I thought I would, I'm sure everyone knows, healthcare reform is a very important and controversial topic right now. And today what I wanted to do in this talk was kind of take it a step back a little bit to talk about what are the fundamental drivers of our healthcare system. And then if we have some time at the end, we can talk about putting, and I'll try to do this as I go through the talk, putting some of those drivers into the context of healthcare reform. Hopefully this will give us all a better sense of how to put some of the arguments floating around out there into context and kind of figure out the real from the rhetoric in the context of healthcare reform. So I thought I would talk about it in the context of the perfect storm. Why is healthcare spending so high in the US? And my overall take on this is that there's really no one reason why healthcare spending is so high in the US. We have a very complicated system, and there are different points in the system which contribute to our high overall levels of spending. So in this talk, we're going to think a little bit about, how do we evaluate high spending, and what are the factors that lead to high spending? Okay, so let's just start at the very beginning. These are data from the OECD showing healthcare spending in the US and other countries. Probably many people are at least generally familiar with these statistics, but this is per capita spending. In the United States, we're number one. Right, so our healthcare spending is over now, this was 2011, over $8,000 per person in the US per year. If you compare this to other countries, obviously this is much higher, right? So these are all the other OECD countries along the x-axis. And healthcare spending, the next closest country is, two countries are Norway and Switzerland at around $5,500. These are what's called purchasing power parity adjusted. So these are generally adjusted for differences in kind of the spending power of people in different countries. Norway and Switzerland are the next two countries at just over $5,000 per person. To make this even more striking, I've divided the spending bars into spending financed by public programs, those are the dark blue bars at the bottom, and spending financed privately by individuals and private insurers, those are the lighter bars at the top. Right, so in the U.S. we have a much greater reliance on private spending, right? So our private spending bar is a bigger share of overall spending than other countries do. But the striking thing to me is when you look at spending in the U.S., the amount per person that we spend through public programs exceeds the entire spending of many other countries, high-income developed countries, Sweden, Australia, Ireland, and the United Kingdom. Those are the ones I've highlighted here. So just the amount we spend on our public programs, which cover less than half of the population, exceeds the entire spending of many other high-income countries. Right, so to me, in some ways, that's the most surprising thing, right? Or puts it into context. Okay, so we clearly spend more on healthcare in the U.S. and other countries, and we're going to talk about why that is. But I want to make a couple important points first about thinking about this higher spending, and these points are related to the fact that for some reasons, healthcare spending should be higher in the U.S. than in other countries. One reason for that is that we're a high-income country, right? And as people become wealthier, they tend to spend a greater proportion of their budget on healthcare. So as you become wealthier, healthcare is something that becomes more important to you, to many people, and they tend to spend a higher proportion of their budget. This is holding other factors constant, such as your health status, et cetera. But it's economists will call it a normal good, or you can think of it as a luxury good. It's something that we want more of as we become higher income. So because the U.S. is a higher income country, we would naturally spend more on healthcare than other countries. The other point that's important, and I think is a little bit more subtle, is that in the U.S., often we spend more on healthcare because healthcare is a very labor-intensive industry. And in the U.S., we have very productive workers, right? So our workers are productive, so we need to pay them more to reflect their productivity. In other industries, such as manufacturing, we can kind of substitute between labor and capital, right? So as workers become more productive and we pay them more, we move more towards capital, machines and things in the context of production. But we can't do that in healthcare so readily. It's not, healthcare is a very labor-intensive industry. We have nurses and physicians and home health aides who help us in the context of healthcare. That means the healthcare industry is competing against other industries for workers. As a result of that, we have to pay those workers more, right? To make sure that we have high quality workers in the healthcare industry, we need to pay those workers more. So one of the reasons, and an important reason why healthcare is more expensive in the US than other countries, is the productivity of our labor force and the fact that healthcare is a very labor intensive industry. This is a similar argument for, why is a haircut more in the US than in China? Right? So we pay our workers more in the US for reasons related to their productivity. Okay, so there are valid reasons why we would spend more on healthcare in the US. People haven't done really comprehensive decompositions on the impact of these factors, but we have a sense that this doesn't explain it all. Even accounting for these things, which are important, we certainly spend more. But this does raise an important question of how much is enough? How much should we be spending on healthcare? Is the amount that we're spending right, or is it too much, or is it too little? Economists have a very specific way of thinking about how much spending is enough, and that is if the benefits of what we're getting from that spending on healthcare exceeds the costs, then it's okay. What we worry about is that we're devoting money to healthcare on services for which the costs are greater than the benefits. Those resources might be better off in some other sector of our economy. We could devote them to education. We could devote them to more iPads. We could spend it in other ways. So that's the biggest concern when we're thinking about overall spending. We have evidence from lots of different types of studies that this is a problem in the US, right? So researchers estimate that maybe between 20 and 30% of the amount that we spend on healthcare provides no health benefits. Right? So that's a really important statement. That's saying we're spending money and it's not obvious that we're getting a lot or getting anything in the form of improved health from that spending. So when we think about, is our healthcare spending too high? To me, this is the big argument, right? So we're spending money in the healthcare system in ways that are not improving our health. Okay, so to kind of put this into context or put this into real life, let's consider the case of colorectal cancer screening. We'll come back to this as we go along. So colorectal cancer screening, there are a variety of different ways that we can screen for colorectal cancer. And it turns out that that those different ways of screening have very different price tags associated with them. So there are a variety of ways. I'm going to focus on two here, colonoscopy and fecal immunochemical testing. Most people refer to this as FIT as two examples. These two tests, this is a much more invasive test. You only have to do this once every 10 years. It's recommended once every 10 years. The price tag for this is $1,200, right? So every time you get a colonoscopy, it costs about $1,200. That's how much the insurer would pay the physician performing the colonoscopy. We have an alternative, which is a fecal test. It's recommended, if you're going to go this route, that you should do it annually. We estimate, by looking at insurance claims, that the cost of that is about $20 per year, right? So the colonoscopy, you get it done in one shot, and it costs $1,200. The FIT test, you have to do every year, $20 per year. So that's going to be about $200 over your 10-year period. Most evidence we have on the effectiveness of these two tests is that their effectiveness is about equal, right? So at the end of the day, your health outcomes associated with these two screening tests are going to be about the same. In the US, the vast majority of screening is colonoscopy, right? So in the US, our system is set up to do colonoscopies. Interestingly, other countries mostly use alternative tests. Some use FIT, others use a different lower cost screening tests. But our system kind of systematically steers people towards the most expensive test. One thing I like about this example, though, is the price difference is very large, right? So you think, oh, are we should we really be doing colonoscopies at $1,200, versus the FIT at $200? But when I often when I'm doing this in class, I will, we're in Silicon Valley, so we use our cell phones and we vote, right, with our cell phones, and the results, pop up right up here on the screen. So when I do this with my students in the class, and I say, okay, you're going to spend $1,200 on the colonoscopy, pretend you're, 50 or older, or you can go $20 per year over 10 years for the FIT. Many of the students do the FIT, but a subset always chooses the colonoscopy. And you can think there probably are valid reasons. You only have to go in once every 10 years. It's a little more uncomfortable, but you only have to go in once every 10 years. So there are probably valid reasons some people might be willing to pay $1,200 for a colonoscopy. But many people, when faced with this price difference, would choose the FIT. Okay, so why do we do so many colonoscopies in the US rather than the FIT? My thesis here is that there's not really one easy answer, but there are kind of three major points or junctures or pressure points in the US healthcare system, and each of those points kind of encourage us to do more expensive things. So what I'm going to do now is kind of build up, what I mean by the healthcare system, talk about what each of those 3 points are, and we'll put colonoscopies into that system. Okay, so you can start by thinking about how do patients access care, right? So we have patients, they want healthcare services, or they need healthcare services, and they go to providers, right? So here I'm thinking about providers very general. Physicians don't usually like being called providers, right? They like being called physicians. But I'm thinking about this a little bit more broadly. I'm thinking about all different types of workers in the healthcare system who provide different types of care. Patients get services from providers, and if we didn't have a healthcare system, they would pay them directly, right? This isn't usually how it works, right? When you go in to seek medical care, you don't just pay that $1,200 for the colonoscopy. It usually goes to your insurance. Why do we have insurance? Why do we have this more complicated system? The reason we have insurance, or the reason our system is more complicated, is that there's an incredible financial risk associated with healthcare. Right? So it's not so obvious in the case of the simple colorectal cancer screening tests, but when you think about something like delivery, for example, a woman could have a normal, uncomplicated delivery, and that would cost about $5,000. She could have complications. The infant could be admitted to the neonatal intensive care unit, and that would cost hundreds of thousands of dollars. Right? So by having insurance, we protect ourselves against the financial risk associated with sickness or healthcare events that is important to folks. Okay, so now we need to introduce an insurance setup. So now instead of having patients, we have people. We have the entire population. And instead of paying directly to providers, now we're sending money into what I'll call payers. Payers are health insurers. These organizations are set up very differently in different countries. So in the US, we have a lot of private insurers. In other countries, the government plays a much more active role in being the healthcare insurer. But people generally pay either taxes or they pay health insurance premiums into payers. Payers then turn around and make payments to the people who provide care, right? So now instead of having the bulk of the payment go from the patient to the provider, now we have a new channel. People have paid money into these health insurers or payers. The payers in turn make a payment to the provider when an individual seeks care. And patients, as most of you are probably familiar with, often pay a little bit or some, or maybe sometimes what feels like a lot, in addition to the payment that healthcare provider is receiving from an insurer. Okay, so this is the basic outline of a healthcare system. Obviously, it's much more complex, but you can think about this as kind of a stylized healthcare system. Okay, so now that we have this system up and running, we can really think about 3 pressure points in the system, 3 places in which we can create incentives to provide high value as opposed to high cost care. When I say high value care, I'm thinking about care for which the benefits exceeds the costs. So for people who would actually rather spend $200 over 10 years for FIT rather than colonoscopy, how can we create incentives for that to happen in our system? Okay, so one of these pressure points is the amount of money that people pay for health insurance, right? And this is actually becoming more important in the context of healthcare reform, right? And what I mean by this is if I were out shopping for a health insurance premium, I would be comparing the premiums across different private health insurers. A health insurer that really funnels people into using tests like FIT as opposed to colonoscopy is going to have much lower health insurance premiums. Maybe colorectal cancer screening by itself might not make that much of a difference, but a health insurer that systematically is pushing or encouraging people to use higher value care would likely have lower health insurance premiums. So one way we can kind of create incentives for using care more parsimoniously or focusing care on high value care is by having people face health insurance premiums. Lower premium plans will often be plans that plans will then have an incentive to structure their systems in a way that provide different types of care. So health insurance premiums is one juncture or one pressure point. Another pressure point is the way we pay healthcare providers, right? So you can think in the context of colonoscopy, a physician who routinely sends people off to get a FIT test actually doesn't make that much money off that FIT test, right? The test is pretty cheap, the physician doesn't have that much to do, but physicians who provide colonoscopies are actually much more profitable by physicians when they are paid every time they do a colonoscopy. Right? So when you think about that, now the physician, say the 2 tests are equally effective, now the physician has a financial incentive to do a colonoscopy rather than a FIT. You could change those payment incentives. You could change the way providers are paid and turn those incentives upside down. So for example, if the physicians were part of a large group and that group was paid what's called a capitated fee, a set amount for providing care to a population over a particular time period, now the physician's incentives are reversed, right? So now the physician thinks, if I steer the person away from the really expensive test, excuse me, if I steer that person away from the really expensive test, then my organization will make more money because I won't have to pay for that very, I've actually lost my water. Here we go. Going way over here to get my water. I'm going to cough more. So if so now that I've capitated the group, now the physician has very different incentives, right? So now the physicians have incentives to provide these lower cost tests. In the case of colorectal cancer screening, I've said those tests are approximately equally effective. So the physician is making this decision across a margin of equal effectiveness. Let's go for the lower cost tests. Okay, so provider payments are another kind of pressure point in the system. We have lots of evidence from research that says the way you pay physicians really matters. Okay, so our final kind of pressure point is the relationship between patients and providers. The issue here is basically how much people pay out of pocket when they seek care. So when I told you about those different screening modalities, one test was about $1,200 and the other test was about $200. In the context of insurance for preventive services, usually those tests, and specifically in this case always, those tests are free at the point of service. Right? So if I have just I think, the colonoscopy might be a little bit better, I have no financial incentive to think about the cost difference between those 2 tests. So when health policy folks talk about the role of cost sharing, they're thinking about the incentives or the kind of the good role of cost sharing in the context of the healthcare system. They're thinking about those types of incentives, right? When people have to pay some out of pocket for the more expensive tests, then they have a greater incentive to really think about the benefits of those tests relative to the costs. Okay, so those are the three kind of pressure points in our healthcare system. We can think about premiums and people shopping for different types of plans and choosing lower premium plans. We can think about how providers are paid, and we can also think about how patients pay for care when they seek services. Okay, so now let's put this, this stylized system in the context of the U.S. healthcare system. Starting with at that first pressure point, when people, are people sensitive to premiums when they choose among different plans? When we look at overall rates of health insurance coverage in the U.S., about 30% of our population is covered by public programs. Those are Medicare for older and disabled folks, Medicaid, generally for low-income folks. The other big payer is our employers, right? So the bulk of the working population gets their health insurance through employers. So now let's think about those premium incentives. Where is the premium signal in those two ways of obtaining health insurance? Starting with employer-sponsored health insurance, employer-sponsored health insurance is really tricky, right? So when you think about how people choose among different employer-sponsored plans when they have a choice, usually they're thinking about their out-of-pocket payment that the employer requires of them when they enroll in the plan. Usually that's a very small part of the premium, right? So when people are choosing among different plans, they're not really usually thinking about the full cost consequences of their choice. But there's actually a bigger issue here. The bigger issue is that when people buy health insurance through their employer, it turns out that premium is subsidized through the tax system. And the reason that it's subsidized through the tax system is when I get my health insurance through Stanford, I don't report that as my wage income, and that's perfectly legal, right? So you guys don't have to go tell anyone about that. Everyone does it. So I don't have to, by law, it's counted as wage compensation for me or anyone who gets health insurance through an employer, right? So when I'm thinking about, should I get, so I have a family, so the health insurance premium for me is about $15,000. That's an important distinction, right? So I could get that $15,000 as cash compensation and pay taxes on it, or I could get that $15,000 in the form of health insurance and not pay taxes on it. For people with high marginal tax rates, say 30, 40, 50%, that is a big price discount, right? So think if cars were subsidized that way, maybe I wouldn't drive a Prius, maybe I'd have a Tesla, right? If I could get that, I could get that big discount on the Tesla. But that's what health insurance looks like in the U.S. So, and it's actually a very interesting policy. It creates a subsidy for health insurance, and I think most people in the health policy world think that is good. We actually want to encourage people to have some health insurance, but the design of that subsidy is saying we are going to give bigger subsidies to higher income people and low or almost no subsidy to lower income people. And that's because that tax exclusion is more valuable for high income folks. Okay, so this is important from that perfect storm argument, because that says those people with employer-sponsored health insurance, they're getting kind of 30, 40, 50% off the price of health insurance. That means they want generous health insurance. They want the Tesla. They don't want the Prius when they're buying health insurance. What does generous health insurance mean? That means health insurance that covers colonoscopies. Right? So a less generous plan would mean health insurance that really funnels people into getting fit. If you want a colonoscopy, you can get a whole colonoscopy in a more generous health plan. Okay, so that's the employer-sponsored health insurance has these incentives for kind of more care or less value-conscious care. Medicare has similar issues, Medicare and Medicaid, but more Medicare, but the mechanism is a little bit different. Usually when people think about Medicare, you don't think about your premium for coverage, right? That's because Medicare is tax financed. So this creates, so we effectively kind of lose that premium signal in the context of Medicare because we're financing it through taxes. The people who are financing Medicare, the people who are using the services now, when they were younger, they were paying into the Medicare system. Young folks now who are paying for Medicare of the currently older population, they're a large and diffuse group. Right? So, and my students, it's really hard to get them excited about Medicare reform, even though they're the ones paying for it, right? I keep trying that, but they're not really receptive. But the point here is there really isn't a premium signal, right? So we think that we need a premium signal to promote high-value care, but the people who are paying for Medicare at a given point in time, the taxpayers, are generally different than the people who are using the Medicare system. So we've kind of lost that signal in the context of Medicare. Okay, so let's think about the second pressure point in the system. That's how providers are paid. The example that I gave you, the providers and physician incentives for doing colonoscopies versus recommending FIT were very different depending how they were paid. When they got paid by fee for service, for example, they had a very strong incentive to do the colonoscopy, but when they were paid that capitated fee, they had a very strong incentive to move folks to FIT. It turns out in our healthcare system, we usually pay providers in ways that promote higher cost care or promote physicians to do more stuff, essentially. We usually pay them by fee for service. We give them a fee for every single thing we do. In the context of hospitals, we usually pay per admission. Right? So as long as the fee covers the costs associated with the admission, physicians generally have incentives to admit people more often. Admit people if you think there's any possibility that they need to be admitted. Probably more controversial is you have very little incentive as a hospital to make sure a person doesn't get readmitted, for example. Right? So if something goes wrong, the hospital actually makes more money if the person is readmitted down the road. So many of our payment systems are geared towards doing more stuff. I think this is related to our last point, right? So we talked about how people have incentives for more to buy more generous health insurance, or we have little incentive to make sure health insurers are delivering care parsimoniously. That translates into kind of little will to change payment systems, right? So now we all want the Tesla, so we all want to make sure that we'll get admitted when, if there's any shadow of a doubt. Okay, the third mechanism here is what economists or benefits folks would call benefit design, right? So how is the health insurance contract designed? And I think this is a little bit non-intuitive what I'm about to say to folks, because I think there's a perception out there that cost sharing has really increased a lot, right? That people spend a lot out of pocket when they go in to seek health care. But if you actually look at the long-term trend in out-of-pocket spending as a proportion of total spending, it has consistently declined over time, right? So in 1970, people paid about as a population, we paid about 35% of total healthcare spending out of pocket. In 2011, we paid about 11% of total healthcare spending out of pocket. And what's the source of disconnect between these two perceptions, the perception and then the actual data? The issue is that healthcare spending has increased so dramatically, right? So that 11% really feels like a lot because the base is so high. We spend a lot more on healthcare. But the general issue is that cost sharing, at least as a proportion of total overall spending, has declined over time. In cost sharing, we have lots of studies that show this is important for how people make decisions at the point of care. So this is equivalent to saying that if I charged people 10% of the price of the colonoscopy and 10% of the price of the FIT, probably a lot more people would go with the FIT as opposed to the colonoscopy in the context of colorectal cancer screening. Okay, so in our healthcare system, folks who are health policy folks who say, oh, cost sharing needs to be higher, they're not necessarily mean, right? They're basically saying we need more cost sharing in order to steer people to making more value conscious choices in the healthcare system. Okay, so that's the overall system. One thing I want to, or how the different incentives at each of those pressure points, in my view, are really kind of pushing us towards using more and using more expensive care. I want to reinforce this idea that all those things work together, right? The fact that we don't have these premium signals leads payers to pay their providers in certain ways, in ways that don't promote high value care. If people were more conscious of the premium, maybe they would purchase a plan that creates strong incentives for providers to use different types of care. But because many of us are getting that 50% discount, and folks who are in Medicare are not paying for it directly, there's not this groundswell of demand for more value conscious care. Okay, am I doing on time? Okay. Okay, so let's talk a little bit about healthcare reform and how healthcare reform is going to hit our 3 points. Healthcare reform, in many ways, is really targeted, or the main purpose of healthcare reform, where healthcare reform is the strongest. This is the Affordable Care Act that I'm sure you all have heard about, especially in the last few weeks, as it's being implemented in many ways. A lot of the Affordable Care Act was about expanding insurance coverage, right? So that's really going to affect this area. Right, so as I showed you on the earlier slide, we have about 15% of the population that's uninsured. Many of the issues in the Affordable Care Act many of the mechanisms in the Affordable Care Act are intended to increase insurance coverage for that 15%. One of the things that President Obama talked about when he passed the act is if you have health insurance now, it's not going to change very much. Right? So I just got through telling you that many of the ways we provide health insurance now are not promoting value-conscious care. So really, the changes to the health insurance market aren't really intended to promote more value-conscious care. They're really intended kind of to bring folks in to this existing healthcare system that we have. The folks who get health insurance coverage, those going to the exchanges, are actually going to see some premium differentials and have some incentive to choose these lower cost plans, but they're a relatively small proportion of the market, right? So there's not a lot of action on the health insurance premium side in the law. If we think about provider payments, most of the reforms that were proposed as part of the Affordable Care Act were focused on the Medicare program. And the reason for this is that the government because the government runs Medicare, the government has much more control over the Medicare, how providers are paid in the context of Medicare. That's important because a lot of provider revenues comes from treating Medicare patients. So there's a lot of experimentation in the context of Medicare right now. And that it remains to be seen. Some folks are skeptical that will actually spread through the entire healthcare system. Other folks are concerned that it might not even make a big dent in the Medicare program. But I think the thing that the Affordable Care Act did that was good in that context was really promote this type of experimentation. And we'll have to watch that as we go along. So I would say that incentives are not strong, but it did put a mechanism in to kind of think about different ways of organizing care to promote higher value care. And in terms of cost sharing, I think there wasn't a lot of action. There wasn't a lot of push on promoting higher value care through higher cost sharing. There might be that segment of the population which is newly insured and it is insured in a slightly different way through health insurance exchanges that might be induced to enroll in plans that have higher cost sharing because they're seeing the premium savings up front when they enroll. But that's a relatively small segment of the population. Okay. So let's go to conclusions, and then we will have some time for some questions. So I think that overall, if you look at the healthcare system, there really are incentives to promote high-value care at those three critical points. The point at which people are paying for health insurance premiums, the point at which health insurers are paying providers, and the point at which people are seeking care. In our current healthcare system, we really have, the incentives are towards doing more and doing more expensive things at each of those points. So in order to get around this, in order to really fundamentally change the incentives of the healthcare system, we really need to think about reform at multiple points in that system. Right? So the pieces of the system work together. The most important example being that when people had incentives on the premium front for choosing lower cost plans, that gave health insurance providers incentives to really change the way they pay health insurers, for example. Right? So when we talk about how complex the healthcare system is and whether the Affordable Care Act will fundamentally change it, I think part of the complication here is that all these points in the healthcare system work together. And if you really want to reform it in a comprehensive way, you have to think about those interactions. Okay, thank you. Okay, let's see. Okay, I'll give you one, and then I got to go to these other guys. Okay, is that okay? Okay.
Well, a while ago, I was curious about what Kaiser would charge me if I didn't have Medicare. It was over $1,000.
That's good.
Now, I pay Kaiser $72 a month. Is Medicare paying over $900 for me?
Yes, Medicare is paying. So you're covered by Medicare. Yes, if you're enrolled in a, let's go back here. So if you are, there we go. If you are, so Medicare, so the things that I was describing are more the what we call traditional Medicare. Medicare pays your health providers. If you're enrolled in what's called a Medicare managed care plan, it works a little bit differently. What happens in a Medicare managed care plan is that there's another step here. This is the U.S. government. This is the Medicare program. The Medicare program pays a private insurer, draw a little circle up here representing Kaiser, pays a private insurer a lot, maybe 90% for your health insurance, and then you pay maybe about 10% for that health care. Right? So even when you're enrolled in a managed care plan in the context of Medicare, the government is giving you a very large subsidy for that care, as they should, because they promised you that care, right?
How much salary do the docs get?
Okay, I gave you one. I gave you one question. I got to go, right? I'm in a medical school. It's a little sensitive, right? I'm going to go green up there in the back.
You didn't talk anything about quality. What's the quality of our outcomes versus other systems? It isn't the issue not just bringing down our costs, but improving our quality.
Absolutely. So quality is important, and quality is very controversial. And I think the reason for that is, in some contexts, that the U.S. is the best in the world is true. In other contexts, it's not, right? So quality can be very variable across different settings, and even across different types of diseases, right? So for example, what's a good quality example? And it plays out in ways that you might not expect. The example that I gave you, quality was kind of constant across those two incentives, or those two different treatments. If you think about, it turns out that we had, I think this one's good. It turns out that we, probably one of the most frequently cited quality metrics is infant mortality rates. right? So we spend a lot more on care and delivering babies, and we don't actually have great outcomes in the context of infant mortality rates. But it turns out if you look at the data more closely, if you are a premature infant, we have very good outcomes. Conditional on being born premature, we have fantastic neonatal intensive care units, and they have better outcomes than other countries. Where things differ in the US is we have more babies who are born at very low birth weight, and then we have, I just saw some very interesting kind of new research presented at a conference where they showed that that the infant mortality rates between 6 months and 1 year are actually worse in the US, right? So I think that's one of those really interesting, it's really hard to make a generalization based on infant mortality rates because in some contexts, our system is really good, right? If you're born as a low birth weight infant, you want to be in Stanford Hospital or an academic medical center. But there are kind of funny things going on at, before the baby's born and after the baby's born that maybe are not so good. Red hat, that's everyone. Oh my gosh. Red hat and blue jacket.
So are there any incentives with the Obamacare Act that will push more people out of employee-based healthcare payments and into paying insurers directly? And is that something that would help the overall system?
Yeah, so that's a really interesting question. And I think that when... Could you repeat the question? Sure. So I think that the question has two parts, and it's about the incentives in the Affordable Care Act in the context of employer-sponsored systems. And the first part of the question is, will the Affordable Care Act really push people out of employment-based coverage? And then the second part is that a good thing or a bad thing? So the first question, the answer to the first question is we don't know, right? And why don't we know? Because it's actually a really hard problem to know what is going on inside a firm and what employers are going to do. And here's the issue. The fundamental issue is that for high-income workers still get that really big tax subsidy that I talked about only by getting their health insurance through an employer. So high-income workers really want health insurance through employers. Now, low-income workers, things have really changed for them, especially in states that expanded Medicaid, right? So now those low-income workers get a much bigger subsidy if their employer doesn't offer health insurance, right? So they get a big subsidy if they go buy their health insurance through an exchange, if they're like a higher low-income worker, and if they're a really low-income worker, then they are eligible for a Medicaid expansion. So now the employer's like, oh no, what do I do, right? So I have some low-income workers, and the best thing for them is for me to not offer health insurance. I have some high-income workers, and the best thing for me to do is to continue offering health insurance for them. So that's why we don't know, because it kind of depends on how employers are going to respond to those trade-offs. And we've seen some really high-profile examples in the news. I think it was Trader Joe's and organizations like that who are, started at that part-time worker distinction, not offering coverage for their part-time workers because, in fact, it was better for them, most of them, to get coverage through an exchange. So what are the cost implications of that? I think the important point here is the cost implications of moving people into exchange or subsidized coverage and out of employment-based coverage. That turns out is also a very interesting issue. So, let's pretend maybe it's possible that people will be more price sensitive when they get into the exchange and make more, value conscious decisions. We're not sure that that's going to happen, but let's just say that happens. That's good for overall healthcare spending in the U.S. And as long as those are high quality plans, then we feel good about that. On the flip side, that is going to dramatically increase government spending, right? Because now all those people are going to get a subsidy, and for the low-income folks, the subsidy is going to be larger than what they would have had under an employer. So there's a really big tension, and I think this is an important distinction that people don't often make when they're talking about the Affordable Care Act, is there are often very different implications for government spending, which is very important, and total healthcare spending, which is also very important. Okay, I'm going to way over to the guy in the red sweatshirt with the glasses, raising his hand really high. Okay.
The question is, I think you've done a good job of explaining the current system. If you were to start with a blank slate, but taking into account, the realities of the world and the U.S., what kind of a system would you design? I mean, how would you design that would give you at least an equally effective, if not more effective, healthcare outcome? And obviously cost us a lot less money. What would you do?
Yeah, so this is a point where I really wish I'd written a book, right? So I could say, and give my answer, and then say, and go buy my book, right? But I can't, so I'm not going to get any royalties from my statement, which is unfortunate. I think the answer is. Oh, I'm sorry, the questions. So the question is like the eternal question. What is the perfect, if I could start from scratch and design a healthcare system, what would I do? I think that it is difficult to reform the U.S. healthcare system because there are lots of, vested interests. That sounds a little negative, but people who are accustomed to doing things in a certain way and kind of like doing them that way. So I think if I had to do it, I would have, there's some things I like about the Affordable Care Act. I think I would try to start here. I would try to start by saying, okay, and this is I'm an economist, and they call us the dismal science. This is an example of why that is true. So this is like one of the most least popular policy prescriptions that almost all economists agree would be a good thing. I would get rid of that employer-sponsored tax exclusion. It seems like such a micro little, problem, like in the tax code, like all our problems are driven by the tax code. But I think it's important. I think it's important that when people are choosing health insurance, they have some sense. I mean, I think even I am astounded. I spend my life studying this, and I am astounded that when I look at how much Stanford pays for health insurance for me, they're paying about $15,000 for my healthy family and I to be covered by health insurance. That seems like a lot. I think that if people actually didn't have a big subsidy and saw their health insurance premiums, private health insurance plans in the U.S. would have much stronger incentives to innovate in really interesting ways. I also think that this is a pretty good time for innovation in really interesting ways because my quality guy up here is right. For plans to innovate in interesting ways, to keep them honest, we really need good measures of quality, right? If I'm going to sign up for a cheaper plan, I want to know that that's a decent quality plan, that I really am getting the Prius, and I'm not getting the what's the low? I'm from Detroit, so I would have said the Chevy a few years ago, but I don't think I can really say that anymore. I think they've improved. But I don't want to enroll in that in the low quality. I want to enroll in a low price plan that provides high quality care, and we need quality metrics in order to do that. But I think the data revolution, things are moving along on that front. Okay, white jacket.
I noticed that you haven't recommended that the government take over the payer system as it exists in Europe. Mm-hmm. Do you not like that system? Do you feel it doesn't work as well?
Yeah, so I have not recommended that. I have for two reasons, right? When I talked about how payers interact with providers, that's really important. In that context, it's actually not obvious that public or private payers, public governments, when I say private payers, private insurers, have an advantage over, either side has an advantage. The types of things I'm talking about, what I mean by that is the types of things that I'm talking about, changing the way you pay providers, can be done either by private health insurance or by public programs, right? So this is a matter of kind of, I think, experimentation to figure out what works and, making sure that these payers have incentives to really, drive efficient utilization of care. So this is an area where I think we don't know exactly what the perfect system looks like, but all the things that we have on the table are equally available to public or private insurers. And the thing that worries me about the one government system is the colonoscopy, right? So, and what I mean by that is that, if we had one government system, we could say everyone should have FIT, right? And we'll just do it that way, and we'll encourage people, through our coverage decision into this test. But remember when I said I kind of liked this example because there are lots of people out there who would be perfectly happy to pay $1,200 for the colonoscopy, and that's obviously not just this test. That's along many different margins, right? So I feel like we are a very heterogeneous country, and the single payer, one size fits all, might not be so good for us, right? So I worry about that. I got everyone going.
Despite the lower cost that exists with a government healthcare system.
Yeah, often it's lower cost, but sometimes, you get what you pay for, right? So, yeah. Okay.
Healthcare. It's terrible. And you want to set that, you want to provide that system for the entire country.
No, I'm recommending English.
Okay, I'm going to have you guys take this outside. Take this outside, okay? We have lots more questions. I'm going to go for the guy standing in the back since he's been standing.
Thanks. The question is, why do you think ACOs would succeed if you think they will, both in the context of the HMO history in the past?
Yeah, so the question is, why will ACOs exceed and draw some parallels to the managed care in the past? So what is an ACO? So an ACO is an accountable care organization. So, an ACO is over here, basically. And what an ACO is doing is an ACO, as I said, reform is really focused on Medicare. What Medicare is doing is basically encouraging hospitals and physicians to get together and form kind of larger, either contractually based or actual, really integrated organizations, and then change the way they're paid. And the way that and it's a little bit complicated, the way that they're changing the payment is they are saying that, organization, we will tell you who is generally receiving care through your organization, the patients who tend to, usually seek care from physicians that you are, grouped with now, and then we're going to pay you a new way. We're going to predict how much it would cost under traditional Medicare for all the care for these patients, and we'll give you a bonus if you come in under that. Right? So it's called shared savings. You provide care in a more value-conscious way, and you can earn some money, and Medicare will save some money. I think that's a kind of a step in the right direction. The problem in the context of Medicare is to make it politically valuable, they really had to water it down a lot, right? So there's not, the magnitude of the shared savings is not so great. Many of you are probably enrolled in accountable care organizations and have no idea. The reason for that is the accountable care organization can't actually make you stay within its network, right? To make this a politically palatable reform, because of our experience with managed care, where it turned out that people didn't really like to be restricted to a particular set of providers, now in the context of ACOs can't make that restriction. So you have to be able to go anywhere you want, right? So that kind of limits the ability of ACOs to really manage your care, and the relatively weak in financial incentives, create weak incentives for them to really even try, right? So I feel a little bit skeptical on the ACOs. Let's see, I'm gonna go with the gray, blonde hair. Yep.
What about alternative modalities and preventive care? Do you have any vision of how that might be worked into the system? Because it's not being used, it's not part of our current perspective.
Yeah, so I'm all for preventive care, right? Preventive care and alternative modalities, I think you mean like alternative medicine, basically. How do they fit into the healthcare system, and kind of what are the opportunities? I think preventive care is obviously very important. The evidence on the impact of preventive care on healthcare spending is that we actually aren't going to reduce our healthcare spending much, if at all, by promoting more preventive care. And there are two things going on there. Preventive care is good because when it works, people won't get sick, and we like that. One issue is that when we look at the population, if I look at all of you guys, I'm not sure who's going to get sick, right? So I have to give preventive care to a lot of people in order to prevent one person from getting sick, right? So that makes it expensive. It might be worth it, right? Because we highly value the fact that, that one person or those 3 people or even those 15 people aren't going to get that particular disease, but it does make it more expensive. The way to make it, more cost effective clearly is to figure out who might get sick and focus your preventive care spending that way, and that's a good thing to the extent that we can do it. But there are very few preventive interventions that literally save money. Many of them are worth it. They're cheap ways to promote better, relatively cheap ways to promote better health, but it's not going to reduce healthcare spending. Okay, I can't give you your follow-up because I've got all these questions. I will stay after and answer people's questions. I'm going to kind of rotate. I'm going to go way over here in the corner. Yep.
About Obamacare, there's a lot of speculation on the financial impact. And obviously it depends on a lot of things like decision-making and execution of the program. But if you had to take a guess, do you think it's going to raise our costs or lower our costs? What's the impact?
Yes, if I were a betting woman, I would say it's going to raise our costs, right? And it doesn't, that's not a very risky statement for me to make, and I don't actually like to bet. So, but when you look at, and this comes back to a comment I made earlier about the cost to the government and the total cost. When you look at the Affordable Care Act, when it was first passed, when folks said the Affordable Care Act will reduce healthcare spending or at least be, not increase it, they were talking about government spending. And there was a very specific reason for that, because the way the act was passed, it had to be budget neutral, right? So for every subsidy that they offered someone, they had to figure out a way to reduce government healthcare spending. And when the act, and this is over a 10-year time period, right, that the CBO, the Congressional Budget Office actually scores these things, right? So when the act was passed, there were increases in government spending, and they were offset by reductions in spending. Those are all estimates, of course, and folks argued about whether those projections were correct, but the CBO said, here's our best guess, and we think it'll be revenue neutral. At the same time, the Centers for Medicaid and Medicare Service, the branch of the government that does the national health expenditures and forecasts healthcare spending, clearly predicted that it would increase healthcare costs. And the reason for that is, as I said earlier, we're bringing a bunch of people into health insurance, right? We have 15% of our population that at a given time doesn't have any health insurance. We're the only high-income country that leaves, a significant portion of the population out of health insurance schemes. When you bring people into health insurance, they use more care, and that costs money. Right? So that idea that healthcare reform was going to reduce healthcare spending was really focused on how much the government would pay. Overall, by bringing more people into health insurance, it will likely increase healthcare spending. There is a wild card here. The wild card is, remember I talked about all that experimentation that's happening in the Medicare program. If if someone hits the jackpot in that experimentation and finds something that really works, maybe that will spread. And the good thing that I think the Affordable Care Act did was create some mechanisms for that type of experimentation. But that's, I think, more uncertain. Okay, red blazer in the front.
In terms of high value versus lower cost, have people looked at the difference, that the real need is for innovation, not cost cutting? And the innovation can only come from suppliers. It can't come from the buyer, the payer. And John Goodman, who did the health savings account, said, I did it because I thought the cost would come down, but what really surprised me was that the innovations that bubbled up from the provider. Now, my question is, do you think 50 million purchasers gave them $10,000 apiece would generate more innovation than giving the money taking the money from taxpayers and then trying to put it out from one source with taxpayer money that's not voluntary instead of customer dollars, which are voluntary?
Yeah, so I think innovation is absolutely important, right? And I think that innovation follows the dollars, right? So innovating, we're here in the Valley, so innovation, people innovate, and the innovations that people think of and actually get to market are those that they think will sell. Right? So in the healthcare system now, we don't have, our incentives are not geared towards promoting what I would call high value, low cost innovation, right? So this FIT test is actually a really good example. So these, innovators came up with the FIT test, and it's so much less expensive and equally effective, but they're having a hard time selling the thing, right? Because lots of people want their colonoscopies. I would say because, they're really not, I'm probably the only person in the United States of America who has said that phrase, lots of people want colonoscopies, right? So innovation. So if the healthcare system were redesigned, in some of the ways I think you're talking about, if people had more incentives to choose these lower cost plans, which are providing FIT types of tests, I think it would fundamentally change the incentives for innovation. People couldn't, it would be harder. So this is actually another really kind of timely and good example in the context of cancer drugs, right? So spending on cancer drugs is, or spending on cancer treatment in general is increasing very rapidly, and a lot of that is due to new biologics, different types of cancer drugs, which are very, very expensive and kind of effective, right? So maybe they increase life by 3 months on average for the folks who are taking the drugs. That is a very difficult decision, right? Should we be spending, tens of thousands of dollars per month for these very high-cost drugs that have some, but a limited effect on expected mortality in the overall population, right? So if the healthcare system clearly said, no, we're not going to buy that stuff, then I think pharmaceutical companies would stop bringing them to market, right? If the healthcare system says, yes, we are going to pay for that, and then we're going to see more of that type of innovation, right? So I think the incentives really matter. Black coat.
It seems to me that the HSA CDHP system helps to unite the patient incentive and the provider cost effectiveness. What does Obamacare say about HSA?
So the question is about HSAs, which are health savings accounts, which are paired with high deductible health plans, and how will the Affordable Care Act influence are they effective, and how will the Affordable Care Act influence their use? I think that HSAs they're going at this, right? So the idea behind the HSA is if you buy, it's like a reward for putting yourself into a high deductible health plan. So a high deductible health plan is a plan that has a high deductible. You have to spend a lot of money out of your own pocket before your health insurance kicks in. The reward for enrolling in one of those plans is you can set up basically a tax-sheltered savings account. They're really good deals. If you guys look into those, like those HSAs are a very good place to save your money. So that's maybe the most important thing you've learned from my talk right now. So if you, in terms of their tax treatment, okay, so there's a carrot, and there's a stick. The stick is being in the high deductible health plan, and the carrot is that you get to save your money in this incredibly tax-favored way. I generally think that that is a mechanism. That's a mechanism that the way that we can promote people promote people to think about using higher value care, and the overall evidence on the impact of high deductible health plans and patient cost sharing more generally is that people do indeed use less care when they're enrolled in those plans. Of course, the thing that we worry about is people are not going to make the right decisions, right? So they're not going to, they're instead of choosing between colonoscopy and FIT, they're going to do neither, right? So that's essentially what we're worried about. So folks who, so that's the kind of the con. That's the thing that people worry about. One of the answers is, can we give folks in those kinds of plans the right kind of decision support, either through their physicians or through new types of information tools, in order to help them make the right decisions in that type of environment. What will the Affordable Care Act do to that? I think it's still a little bit unclear. I think there will be plans, and the issue here is that under the Affordable Care Act, the plans, there's a minimum kind of generosity level for plans, that plans have to meet in order to be considered qualified coverage, so you don't have to pay the penalty, the individual mandate penalty. And the question is, can you design a high deductible plan that qualifies you for the getting that nice health savings account and still meet those qualifications for the minimum benefit generosity? And I think there have been some plans that have actually met that criteria. So I think they will still stay around, and it depends on people and how the Affordable Care Act shifts demand for different types of coverage, whether they'll be popular.